It is like somebody trying to focus on the tie and the bow when I'm not even ready with my undergarments.
When I was in the National Consumer Commission, I was hearing a case, one Ayurveda doctor posted in a remote rural area of Madhya Pradesh. He performed a cesarean section upon a lady. Something wrong went up, was there. So during the course of hearing, I asked the doctor, why have you done it? So he told me, sir, in that 15 to 20 kilometer of radius, I was the only medical professional available. The lady came to me in a very precarious condition. Had I not done anything, even then you would have blamed me.
It is high time, and we have got all legal luminaries also over here. It is high time, definitely, that we have some white paper on this, and we wake the National Medical Commission, discuss this with all the stakeholders, and come up with some, definitive rules, regulations as far as this privileging is concerned, so that the medical practitioners, not only the medical practitioners, but even the patients, especially in the small towns and rural areas, can definitely gain from this practical training that a senior doctor has received in that particular subject.
Major concern is how far this privileging is promoting the patient care process, patient centeredness, and patient safety, and also looking at the patient need as the central point. Privileging has to promote the transparency, accountability, and even autonomy to the doctors. So when it comes to, many times we talk about competencies and skills accordingly giving the privileges, sometimes it will reduce the autonomy of the doctors. So we need to see that they are highly empowered. Time to time, they are given opportunity to utilize the given chances. That is one. I'm afraid that when we go into too deeper of privileging, working on integrities, it may reduce the medical professionals. Sometimes it may demotivate also.
First and foremost, we must understand and accept that while today we discuss the privileging related to doctors, within the medical cadre, there are multiple other privileges that are required. We are talking about privileging of nursing. We must remember that this is a movement which is evolving. I'd like to keep a general note of awareness for all our esteemed policymakers, doctors, hospital administrators, my accreditation colleagues, as well as, of course, the patient voice. Please do not forget the voice of the patient in terms of patient safety. Please do not forget that we have got an India where we are happy to discuss that we've got MCHS to deal with our cardiac surgeries. But remember that there is also Bharat. There is a big Bharat sitting out there where we don't have those privileges, because essentially at the end of the day, it costs an X amount of rupees to buy out your rural practice and, pay the government and say, I don't want to go to a rural area. I'd rather sit in Mumbai or Delhi and go ahead and complete my practice. We must not also forget that while there are huge vested interests, there are financial equations and so on and so forth. Our job today is to focus on policy.
I manage a hospital in a city, and also I manage a hospital in the rural area. Now, I think when we talk about privileging, we need to look at the very aspect of where the hospital is situated actually, because is our country really ready for privileging? Are we having the patient and doctor population ratio which is equivalent to an advanced country which is following privileging? Law should actually look at the perspective of whether it is a corporate hospital or a hospital in a city which has got good availability of doctors, or is this privileging available for a person who is in a village or in a small town where they're practicing? If you look at a patient population ratio with doctors, we find we are slightly below 1. And it comes to an advanced country, they are having six doctors for 1,000 patients or 1,000 population. But whereas India, we are at 0.89 as of 2021. So by we doing privileging, are we dragging our ratio still lower to 0.89?
So what I feel is in India, privileging, yes, it has to be there. But I believe at present, the legal system and the societal system and the probably even the medical system that we already have in place, which is quite, it gets upgrading every day, is not in a position to have such a thing, especially in the rural area.
We need to somehow, first of all, strengthen the basic systems in place, then on to move on to privileging, and that also should be institution specific for a particular period. It's a definitely a very interesting topic, has been made more interesting by the court pronouncements.
I think the whole issue of privileging first has to start with good communication with the doctors themselves. So it's the doctors who cut down the other doctors and tell them that person was not qualified, or this person did not have the specialty, or so and so person had no authority to do whatever they did. So if that communication becomes better, I think this whole issue of privileging can be sorted out to a certain extent.
Establish comprehensive and standardized criteria for evaluating the qualifications, competence, ethical conduct, and experience of healthcare professionals seeking privileges. This criteria should be regularly updated to incorporate advancement in medical practice. 2I, robust vetting process. Implement a rigorous vetting process that includes thorough background checks, verification of qualifications, peer reviews, and assessments of clinical skills and ethical conduct.
My view is this ought to be introduced in stages. We are not ready for total privileging at this stage. It has to be situation-wise, location-wise, and based on input from all of you.
Friends, there has to be privileging. There is no doubt about it. But only thing is that Justice Sareen was rightly putting it. It is to be decided that at what stage, at what speed that we have to bring this particular in. It can't be overnight. We are in a developing stage. And in that developing stage, to expect everything according to the Western world countries, developed countries, that will not be befitting. We must be very careful and we must be mindful that we have typical circumstances in the country, our literacy rate, our understanding rate. I like your comment that there should be something like, on mobile you put my doctor and my treatment. I think that will be excellent. But then that time is yet to come. However hard you try, the difference between the rural area and urban area will not be able to gap up so easily. That will continue to be there, and the legislatures will have the extra burden on them while framing any law, that they should keep that particular difference in mind.
The first step that we take is, I think these privileging, and this is what I had done when I was the president of the Maharashtra Medical Council, where there have been, those people who have been practicing this particular oncosurgery, gynec oncosurgery, cardiothoracic surgery, they were doing it for years, but their institution said that since you are just an MS or you are an MD, you are not allowed to do this in the institution. So they came to us in the council saying that this is my experience of doing it. And even in the government service, I have been doing the same thing. Why am I not being allowed to do this in a private setup? And there we took some steps after due discussion in the councils, where we asked them to give their credentials of where have they done this, where have they taken the basic training. If it is there from a institute which has been recognized by the councils, by the MCI at that time. Not only that, we took a letter from the deans and the superintendents of the hospitals in which they were working, that this particular doctor has been doing this oncosurgery for so many years, and so many. So it's just like a logbook, though we don't maintain, unfortunately, in India, we do not maintain the logbook. I think that should be made compulsory in the future also, even in your private practice, to have the logbook, because that will tell you if you are empowered to do that particular surgery or not. And taking all this into consideration and discussion in the councils, we have given them a special letter of consent to do that particular onco surgery or do that cardiothoracic surgery. So I think what we can do is, since the state councils are empowered to give you the credentials, I think the state councils, and this is what I think discussion I will put forward, because I still have contacts in the National Medical Commission, put forward to the National Medical Commission also, that the state council should also have the powers initially for privileging this.